Got that. And now to stop it. How do we stop the recording? Um, well, what I'm doing here today is I know there's a lot of people with different skill levels, different experiences. They've done things, gone to courses. If you're anything like me, a general practitioner, and don't have specialty training, then you've gone to courses right and left, and you heard things and myth, and then you're faced with realities, and then you don't know exactly what works, what doesn't work, and we always suspect ourselves. We always think there's something wrong in the way we do things. So I'm starting from the very base. We're going to go with anatomy. So bear with me if you find some of that stuff to be basic. It isn't, okay? Because the devil's in the details. Right when you think it's all very basic, we're going to find something, a tip or a hint, a pearl or something that can help in bringing about the results you want doing sinus lifts. Generally speaking, sinus lift procedures are one of the most predictable procedures that we can do in dentistry when it comes to bone grafting. So why do we resort to sinus lifts? Is because we've had a velar bone loss, reduction in volume, be it vertical or horizontal. So the only way to restore is to access the sinus cavity, place the bone, and wait for the bone to harden, coalesce around the implant. Sometimes we do implant placement at the same time. Sometimes we wait for healing to place the implant. But today, you may find that the way we're going to propose doing sinus lifts to be challenging to most traditional methods that we've learned or we've heard. We're going to dispel with a lot of myth, a lot of fears. And hopefully by the time you're done with the presentation, you have built a good mental picture, combine that with a surgical skill you have, and then go back and not ever be afraid of attempting, a sinus lift for whatever reason. Okay. Antrum of Highmore, sinus, maxillary sinus, pyramidal shape, as you all know. We know that it drains at the very top, okay? There are a couple of anatomical landmarks here that I would really like to direct your attention to. I mean, if we look at this picture right here, this slide, is there anything that you don't know in this slide? I mean, you can see the sinus floor, you can see the lateral wall, you can see the medial wall, you can see the nasal cavity, the orbit, the infraorbital. You're going to get all this, so please, no photos. You're going to get the whole thing. Concentrate, okay? And then that sinus drains at the very top, okay? So, are you all aware of the ostium, the osteomeatal complex? The osteomeatal complex is the very area where the sinus empties its contents, okay? The sinus lining, it has epithelium, ciliated epithelium, and it moves, and the cilia move, and they move upward, and they push everything upward. And the drainage is at
Good morning, Dr. Carmi.
Good morning.
Good morning, everyone.
Good morning, Dr. Christine. How are you?
We miss you.
We miss you too. Can you hear us?
Yes, very good, very good.
Okay, very well. Can you
And
see
I
the
can
screen?
see your handsome face too.
Hold it long.
You see it?
Yes.
Oh, no, I don't see it. All right.
You
Thank
me?
you. All right. Are you familiar with the slide now? Okay.
Yes,
Very top, there's that ostium. The ostium is where where the sinus empties everything. Okay. When we are planning our sinus grafts, we must take a full CT, not just to see uh, the alveolar process and maybe just a few millimeters above it. We want to see everything. We want to see the sinus floor. We want to see the infraorbital floor as well. Okay. We want to be able to see, and we go sequentially. We go from right to left, and then we're looking at, and we're going to go through that. But this is one of the main areas that you must pay attention to, the osteomeatal complex. It's right there near the top of the sinus. And that's why we are deathly afraid of any bone grafting material traversing through the sinus floor, through the sinus cavity, because if it's lodged up here and it blocks the osteomeatal or the ostium, that becomes a problem. Now, if I go back to the slide right here, at the bottom of the orbit, what do you see? There's a little dark dot. What could that be? It's a nerve running in bone under the orbit, the infraorbital nerve, okay? Now, we see here, and that's where it's found a lot of times, okay? Most of the time, okay? You find it in bone. Yet sometimes it drops down, and I have a slide, an actual CT that I'll show you. Okay. Floor of the sinus. The floor of the sinus can be the main reason why we would have difficulties for a number of reasons. One, if you've done any sinus lifting, if you try to move the membrane, most of the adhesions are on that floor. The most irregularities are on the floor. And if you have septa, they're going to be in that floor. And we are going to address each one of those things too, okay? And can you properly assess anything without a CT? Can you do it on a panel? Or now, if you're in this class, you know that only a CT is acceptable. I've done a few earlier in my career with panel, and I think I got very lucky, but I really don't want to ever do that again. And if you are going to attempt a lateral window sinus lift, you must take a CT, and you must be able to assess the inferior floor, the medial wall, the osteomeatal complex as well. Okay. Now, these are some of the functions. I really don't need to go through that. You're going to see it. One of the things, it has mucus and serous fluid. It warms the air, resonance of sound, protection of anatomical structures, a lot of things. And it's part of the immune system as well. And you can smell a little bit with it. Okay. What is a sinus lift? What do we do for a sinus lift? Well, we're doing it once you take a tooth out, okay? You start losing bone from two directions. You're using bone from the crestal portion, and you're using bone from the coronal portion. So both area, you're going to be attacked from both angles. The top is going to drop down, and the bottom is going to creep up. And then you are left with what we call pneumatized sinus. Okay, so when you have a pneumatized sinus, what you want to do is you want to take the membrane, push it up, and place some kind of material in there. In most cases, okay, there are times when you don't need to place any bone in there, and you can still get good results. And then you add the bone, then you place the implant, and then the restoration. Now, Maxillary sinus is free of any acute or chronic infection or sinusitis or pathology, cyst. That's a big question mark. If you see a patient that has a mucocele or thickened membrane, do you still proceed or do you wait for it to resolve? Do you send them to an ENT? And the answer is one of two, either yes or no. If it's yes, you're going to, not do the procedure and send them to an ENT. What are you waiting for when they come back? What do you want to see? Or if you say, no, I'm going to proceed, then what must you do at that time that you access the sinus? How do you deal with the membrane and how do you deal with the pathology that's inside? And we'll go through that too, okay? So this slide is a basic slide, okay? And what's on it is, this slide is the same one that I had last year, except the very last portion. I added a little something there, okay? Because I've had a little bit of paradigm shift that things actually can go on even if you have some sinusitis. To what level? At what level can you proceed and at what level can you stop? That's what we're going to find out. When not to perform sinus lift. Heavy smokers, what's heavy smoker? 5 a day, 10 a day, 2 packs a day. Acute sinus infection, yes. Recurrent history of chronic sinusitis, maybe. Uncontrolled diabetes, if they have uncontrolled diabetes, their chemotactic factor is suspect, and we're going to get their diabetes under control before we proceed. Otherwise, their healing capacity is very compromised. Hyperplasia, cystic fibrosis, or a malignant tumor. I would argue that heavy smokers, I want to know what level they're at. And I'm going to say something that's not going to sound very popular in medical circles, but if they're somewhere between 5 and 10, or if you can bring them down to somewhere between 5 and 10, you can still proceed. If somebody's smoking 2 packs a day and they haven't quit, you're not going to make them quit for a sinus lift, okay? But if you can work with them on having them reduce the amount of smoking they do to a manageable amount, maybe you're able to help the patient then. Acute sinus infection is in my books, is a total no-go. If they have an acute sinus infection, I'm going to show you pictures of acute sinus infections, no go. We send to an ENT, get that resolved, and then we can proceed. Recurrent history of chronic sinusitis, we still proceed, okay? There's a little bit of management that we do here. There's a little bit of management that we do with, if they have chronic sinusitis, especially if it's not of the, very severe kind. But keep in mind that patients with chronic sinusitis are prone to something else, and we're going to talk about that later on. Malignant tumors, nobody wants to deal with patient who has malignant tumor. They have bigger issues to deal with. Let them handle that. And then later on, we have to do some very, very, detailed assessment of their, if they received any radiation or not, any chemo or not, if they're on any chemo or not, okay? What are the local contraindication? Who is the patient that you would have to do some maneuvering before you access the sinus, okay? Bad oral hygiene, of course, that's the main thing. Remember when we were talking about, our treatment planning? First thing that we do, we assess what? What are the 3 things that we assess? We're assessing hard tissue, soft tissue, and occlusion, okay? And then once we're done with our assessment, we start our treatment planning. Number 1 on our treatment plan is get rid of infection, okay? If they have perio, if they have an abscess, that's the number 1 thing that we attack right away, okay? So perio comes before sinuses. Somebody with bad oral hygiene, untreated periodontal disease, gross malocclusion, you know, if they have, you know, xerostomia, all those things that are going to interfere with general hygiene. This is going to bring about some very, very unwanted visitors in the area of the very virulent type. Before you think about implants, you must think about
Are you sure you're in the right?
restoration, okay? Are we going to be able to place a crown or a bridge in that area or not? Have you ever seen a case like that before? Where you're done? And then there's not enough space in the posterior or in the anterior, and the lower anteriors are hitting the palate. Okay, so manage that before you proceed. Okay. Bone density is going to be something that's vital to anybody who's placing implants, not just doing a sinus lift. Okay, so you can assess the Huntsville unit through our CT function. Okay. Now you might wonder, what numbers are we looking at? 150, 200, 300, 500, 600, 1200. Okay. Good cortical bone is going to be somewhere between 900, 1200, 1300. Okay. My go-to number is somewhere between 3 and 600. Okay. If I find this number, then I'm comfortable placing in implants. If it's 3, what I'm doing is I'm going to think about ways to condense the bone in the area or to add bone. If it's 800, then I'm not worried about bone density. So why do we worry about bone density? What is the thing that we're looking for when we place implants? Right, but why do we need a lot of bone around the implant? Stabilization, which comes from what? Bone, BIC, bone to implant contact. How much bone is actually around the implant? If it's fibrous tissue, it's no go. That's why we need good bone. Good bone. If we don't have good bone, we condense. If we can't condense to good bone, then we come up with way. And if our last lecture about bone grafting is when we addressed all that. Okay. Where are you more bound to find bone that's not very that's not very dense? Where do you find that mostly? Mandible, maxilla, right? Posterior maxilla usually, okay. The anterior maxilla, we lose the bone most of the time. It thins out. We lose it. Posterior maxilla, it's like an egg. You know, you still keep the shell, but you go in and you can almost pierce it with, you know, with probe, or if you apply a lot of pressure, you can almost do it without doing anything. So it's the posterior maxilla. And where do sinuses reside? In the posterior maxilla. So it's something that you always look at. Okay, here it is. Bone to implant contact. The less bone around the implant, the more prone you are going to get, because we get what happens to implants, what happens to bone after we place implants. Remember Dr. Weaver? Huh? Bone remodeling, right? And bone, if it's live bone continues to remodel throughout their lives, okay? So the implant is going to have bone around it, moving in and out. And if we don't have a lot of bone around it, then you've already doomed the implant, the periodontic. I would like to discuss something about implant size. Bigger implant, smaller implant, what do we want? Dr. Vahid, what do you, in a posterior area, what's your go-to size?
I try to place the biggest diameter, not so much emphasizing to height
Okay. So you go for width,
width.
not length. Okay.
If I don't have width, then I try to get the length.
Then you try to get that. So that opens the door for short implants, if we have the bone.
Right.
if we have the bone. Dr. Anu, what was your thinking before you started with us?
You judge the amount of bone you CT, and then based on that you choose. And then my thinking needs to be you cannot go very short. So that you feel like stumbling block, but sometimes there's not enough depth. There's not enough depth, especially like in the posterior mandible, sometimes when the inferior alveolar nerve runs really close. Then if you don't if you don't have enough space, then you're not place an implant.
Okay, so you're saying, my question is, do you have certain width for the bone? Do you try to use as much of that width?
You want to keep at least 2 millimeters, buccal and lingual,
Okay,
and then you don't want to you don't want to fill the space with metal, but the optimal metal based on prosthetic and also fill.
very good.
So
So what's our go-to size?
4
By
5 posterior. And
4x10, I'm like a premolar anterior, a 4x10 implant, okay? In a sinus, what would, like, we're placing for a molar. We always go for 5, but what if you don't have the length? What if you don't have the width of the bone? If you don't have the width, then you increase the length. And what if you don't have the length? What if you don't have the bone? Then you're doing sinus. I'm seeing a lot of schools. I'm seeing European schools. I'm seeing South American schools. I'm seeing American schools. It seems that everybody right now is trying to coalesce around, especially in grafted bone, okay? If you have the width, a 5x10 is a good size for a mold, okay? But if you don't have the width, it's okay to go for a 4x10. Now, I must warn you, okay? The type of titanium you use is very important. And in June, we actually have a few cases that I'm going to show you where there were implant fractures. I just got 4 implant fractures this week, okay? If you don't use the proper implant with the proper, that has the proper titanium alloy, you are going to get implant fracture, especially in the molar area. So, not mentioning any brand in particular, but if you use any implant that has type 4 titanium, a 4 in the posterior is going to will have to withstand a lot of forces, and it may break. Okay, so this brings us to the question of how long of an implant to place. Now you're doing the sinus lift. You got the bone, you've got the runway, you can do all you want, okay? What implant size would you place? Would you place a 4x10, 4x13, 4x16? And you're going to see some x-rays here where they placed 15s and 16s and even 18, okay? I know 18 is good for pterygoids, but not for a sinus lift. Now, this number is very important for one reason. I want you to remember this. Okay, and this is one of the important numbers you'll have to remember if you're attempting sinus lifts, okay? The average height, again, the operative word here is average, okay? From the sinus floor to the osteomeatal complex, to the ostium, okay, is 40 millimeters, okay? So if you lift 20, okay, and anything happens, that sinus is going to suffer from it. Okay, so that height is about 4 centimeters, okay, from the alveolar ridge to the ostium, okay? So placing long implants, very long implants in a successful sinus lift case may not be needed, okay? I personally would be more than happy with a 5 by 11.5 if I have the width and the height. Okay? And we are going to show you some very, very interesting x-rays here. Okay. Now remember, everybody's crazy about classification. Okay. We don't do classifications. Brilliant people do classifications. You know, academicians do classifications. You know, Dr. Avida and all these guys, and you know, in the university, they do papers, they do classifications, and the most famous one is actually by Dr. Mission Judy. Okay, it's a very, very famous study by Mission Judy. Okay, and they have A, B, C, and D, and it all has to do with the height of the bone below the sinus. Okay, the bigger the height, the higher. So it's A is plus 10, you know, 12 plus. B is 10. C, do we need to know all that? Do you need to remember those classifications? I don't know. Those are the kind of things my memory tends to discard very quickly. But what I want you to know, and what I want you to understand, and what I want you to keep in mind at the forefront of your brain every time you're looking at a CT is the remaining bone height, RBH, and the remaining bone width. What kind of bone do you need in order to place an implant with your sinus lift? How high can that ridge be? 1, 2, 3, 5. If you have a 3 mm height and you do a sinus lift and you didn't pack well, and you place an implant at the same time you do the sinus lift, what might happen? The implant can be in the sinus, okay? It can go in the sinus. So that's because we never had enough bone, alveolar bone, to give us that initial stability, okay? I must warn you, there's a little caveat to that, okay? I try not to place an implant unless I have 5 mm of bone height, okay? I have the proper width, but the height, 5 mm or more, I'm going to place the implant. What is going to happen to the bone after you open the flap? Okay, remove the periosteum, which is the blood supply. Okay, you're going to get bone resorption or bone remodeling. Okay, so your 5 mm ridge could end up being 4, 3. Okay, and then what might happen? You may not even get bone formation around the head of the implant. And if you didn't pack your sinus well, okay, that implant could very easily fly in the sinus. Okay, so yes, my comfort zone, my own comfort zone is 5 mm. Remember, don't commit to a number. Don't think of a number and think, okay, it's 5, I'm going to place my implant right away. Okay. One more thing to consider while you're prepping.
It's a waste of time. No, what if I gotta get some?
How do we
Listen to yourself. You're gonna ask something.
Dr. Lee? I don't think you can hear.
Yes, I'm sorry, I'll turn off.
Okay, thanks. One more thing. The way you prep your bone, okay? The way you prep your bone, can you really tell if you've overheated the bone or not? I mean, sometimes I guess, sometimes I can guess, okay? I feel like I feel this bone is not going to do very well. So I take if I still have the bone, I'll take a fresh cutting tool and I will just try and remove the burnt area of bone. But if you don't know, if you're not aware of that and you place your implant that bone may not rebound to health easily, may not turn over to healthy bone easily. You know, you may not be able the osteoblasts may not reconstitute themselves in the area as easily, okay, and overcome all the fibrins, you know, all the fibrous tissue that's a lot faster than bone to grow in the area. And you may end up with fibrous adhesion to the implant, and then you may not end up with an implant to the sinus, but you may end up with an implant that failed. Okay. Just last week, and I think Dr. Tu and Dr. Lee were there. We had a case. The patient is coming in. We're exposing, and we took a quick panel, and the implant is in, you know, is in its spot. We opened the sinus, and I opened the flap, and I can't even find the implant. I didn't touch the implant. I just opened the flap, and then I saw a black hole. And then I took an X-ray, nothing, another X-ray, nothing, a panel, and there it is sitting way in the back. So it happens. I did the surgery, so I'm assuming I did something wrong. I think I know what I did. Now, if an implant fails, okay, you want to know why it failed, okay? I get really bothered if I don't know why the implant failed. Okay, that's what kills me the most. If I did everything right, or if I think I did everything right, and I still got a failure, what do? We blame the implant company, right? This is a shitty implant. I'm not buying it anymore. That's not true. Okay, it's usually the operator. Okay.
Dr. Carmi,
Yes.
that case, the guy was a heavy smoker. Because I know when we did it, I told him he has to quit smoking. And then every time I see him, I smell his smoke, a lot of smoke around
Oh.
him. And so I bet he's packing, at least doing a pack at least a day.
Oh. Yeah, but that implant didn't make it. The rest did. All the other 9 implants did, so we're good. But I think I should not. That implant was placed at a site of a molar there, so I don't think the bone healed around that implant, and that's why I don't know why it sat in his mouth for 5 months, and just when I raised the flap, it fell out. That, you know, that I don't know. You've all seen this slide many times before, okay? That's what happens to bone. And the one on the very left there, the top left, is the one that we find often with people who have lost who have lost their teeth. You know, they lose first molar and then a premolar gets a cavity, and they get a root canal and a crown, and it fails, and then it's out, and then number 2 leans over, and then it's out, and then they get a partial, and they come back, and it's 15-20 years later, and you hardly have any bone height. Okay. So these are the classifications. Division A. Good bone height. Honestly, if I have 10 or 13 millimeter bone, I'm not doing a sinus lift. Okay. And 5 millimeter width, that is not very wide. What's the minimum I want? 8 in the posterior. I really want 10, 9 to 10. Okay. And mesiodistal length, I want enough to place at least a premolar. Okay. What's with the 30-degree angulation? For the restoration. Okay. How am I going to place the implant? Am I going to place it so it's pointing out of the cheek or pointing out of the palate? Okay. There's a little room there. There's an envelope of motion. Okay. And straight down, 0, 30 degrees at the most. Okay. And there is a case that one of you is going to be doing in May. And while I was prepping this lecture, the patient came last week, and he's got 3 implants, 13, 14, 15. very well placed implants. They're parallel, integrated, in good bone. So I know the doctor did some good courses and has good hands. Okay, except the angle at which the implants are placed buccolingually is, and you will see, is causing a lot of troubles to a point where we actually have to take out everything and redo it. And you will see, I will go through it. I will go through that case, not just with the, the doctors that are doing it, but with the whole class, because I think it's a very, very important case to see.
Doctor, what is sinus to eye ratio?
Crown to implant ratio. Okay. What's crown to root ratio? Crown to root. One. Crown,
One portion of the crown and the portion of the.
yeah. Crown to root regular is 1 to 2. What is it for implants?
At least 1 to 1.
Okay. Okay. I'm not going to answer. I'm going because I want you to come back for the May lecture and pay attention and ask me about it. Okay. All right. Division 2, less bone, less height, less width. Division 3, even less, okay? So on and so forth. So far, I haven't challenged any of you. So far, this is all basic. This is all stuff that you know. This is all stuff that you could have stood up here and narrated yourself. Okay? Okay. I'm going to skip over this. You're going to get this in your when I email you the presentation. You can go over it. If you want to memorize it, you can. Okay, these are the Hounsville units right there. Somewhere between D3 and D2 is where I'm comfortable. Okay, I'm not comfortable around D4. The implant doesn't have a lot of bone to implant contact ratio. And I'm not comfortable with D1. Okay. D1, you're placing a screw in glass. Okay. Cortical bone has BMPs. Okay. You take a piece of cortical bone and you grind it and you add it to your graft. Okay, it's gold. But it lacks vascularity. It doesn't have the blood. You need the blood. Okay. So I'm not comfortable with 1. I'm not comfortable with 4. 2 and 3 is where we always want to be. Okay. Very good. All right. If you ever attended any lectures, if you ever read anything, the word Tatum is going to pop up, here and there and everywhere. Okay. We owe a lot that we know about lateral window through Dr. Tatum's approach and studies. Okay. What he did was taking autologous bone or taking bone from the human himself, like tibia, jaw, anterior, take that bone and mix it and then put it in the sinus and do the graft. In my mind, I think that is the gold standard. Okay. And then in the 80s, Dr. Tatum started using synthetic bone. Okay. And then let me tell you something. In Europe, they are not allowed to use cadaver bone. Allograft. They don't use allograft. Okay. In Europe, they use xenograft, synthetic bone, whatever it is, Minros, all those brands. Okay. And if you're familiar with Geistlich, you will find those types of brands there. And the European, and I've always been against it. I was like, why do they not allow it? And I really don't like having xenograft. I don't like it. I don't like having it in the socket. I certainly don't like having it in the sinus, especially if I have to count on it 100%. Okay. That is also one of the myths we're going to do away with. This is one of the things that caused me to have a little paradigm shift as well. Okay. So, in 1984, Dr. Carl Misch, based on, he did his classification based on the amount of bone below the antrum, below the sinus. And then in 1986, he added also the amount of bone width. Okay, so we added the vertical to the horizontal. Okay, in 87, they included the technique of the sinus floor. Okay, what are we going to do here? And then surgical approach, the grafting material, timetable. How long do we wait? Do we wait 4 months? Do we wait 6 months? Do we wait a year, 9 months, 12 months? All of that. Right now, we are standing on the shoulders of giants because we have a sure method, we have materials, we have methods, we have approaches, and we have years and years, maybe 30 years of studies of things that work. And this is what we're going to, I'm going through a lot of basic stuff, through a lot of things that worked sporadically, not consistently, but what we're doing here today is that we're going to water everything down to where you have a checklist. You go 1, 2, 3, 4, and proceed. Okay. So let me go through another aspect of the anatomy here. The anterior wall. The anterior wall of the sinus is the one that's closest to the nasal cavity. If we open our window too far distal, I have done that, okay? What happens when you open your window too far distal? You're doing a sinus lift around numbers 2 and 3, okay? Why do you want to go all the way to 4 and 5? Why do you want to go all the way to premolars? You don't, right? Or 3 and 4. You're thinking you're just going to have this little balloon of bone right above those 2 teeth, the molar and the premolar, and we'll call it a day, right? Because if you want to extend your lift, what's going to happen? You're going more into a blind side, okay? And when you go into a blind side, what could happen? You could get perforation. And what are we deathly afraid of? Perforations, okay? Well, here we're going to make our window as far as anteriorly as possible. We're going to leave just about 3 to 5 millimeters, okay? And that's going to be our most anterior cut, okay? So identifying where the anterior wall of the sinus on your CT and what tooth it correlates to. Because what you see on the CT, you open in the mouth and now it's a little different, right? So look at the CT and try and do a landmark. You say, okay, I know my anterior wall is going to be right above number 4, and I'm going to extend my window there, okay? And is it going to go straight down or does it have a curve? So from your CT, identify your anterior wall, identify the floor, and your anterior cut must extend as far anteriorly as possible. If you don't, you increase the area of your blind spot. We have blind spots in sinuses anyways, okay? Okay, your lateral wall. The lateral wall is probably the easier one to open, as long as you're over the first molar. Once you start getting posteriorly and superiorly, what are you getting close to? The zygomatic bone. And what kind of bone do we have there? It's thicker, it's harder, okay? So every area has its challenge. You got to keep that in your mind. As you move posteriorly and as you move superiorly, you're going to get to thicker, harder bone. So also identify on your CT how far posteriorly you're going, how far superiorly you're going, okay? You don't want to be too high because you start cutting into the zygoma, you're probably, it's going to be half an hour, okay? You're going to remove bone that you really don't need to move. You go too far superiorly, what could you be close to? infraorbital, okay? So you have to be able to identify the infraorbital as well, okay? Now, this picture right here. You see the top, the two arrows, okay? We're pointing to the orbital floor, okay? Thin orbital floor, the infraorbital nerve and bundle is, is somewhere around there, okay? Sometimes you see those two hair-shaped, okay? Sometimes that's the infraorbital. Sometimes it hangs down like it will hang down like a little like a bulb from the floor. It will hang down. So when you're cutting through your CT, you're not only going mesiodistally, you're also going anteroposteriorly. Okay. So you're looking at the nose and you're looking at slices going back towards the back, towards the brain, you're going, towards the occipital bone. And you want to be able to visualize the full maxilla, the whole membrane, the whole sinus, and then you want to start seeing the infraorbital floor and identify your marks. Okay, this is very important because that's certainly going to interfere with how high we can open, how high our window can be, and we can cause injury to that nerve. Okay, which we don't want to. Okay. All right. Again, in the anatomy of the sinus, I want you to be able to visualize this. I want you to be able to move your CT and adjust it to where you can see the ostium. Okay. You want to make sure it's patent. Okay. It opens into the nasal cavity and it drains. And if you don't see this patent ostium, okay, then you're going to have problems later on, or you might run into some severe problems. Okay. Again, and the infraorbital nerve. Okay, sinus membrane. Sinus membrane is a very, very interesting. This is what we're doing this course on, right? This is what we're handling, the membrane. Okay, that's all. We want to access the membrane, we want to lift the membrane, we want to protect the membrane. That's what we're doing. How thick or thin you think that membrane is on average? How thin you think that membrane is? What's the average thickness of the sinus membrane?
0.1. I mean,
Okay.
0.5.
Okay, here. Okay. The average number between 0.3 and 0.6. Okay. Now, that's not very thick, is it? It's not even a millimeter. Okay. You can very easily get it caught underneath your curette and it will go just like that, right? And this is why we're all here. That's why we keep on, that's our holy grail. This is why we keep on taking courses, wanting to practice more and more. Dr. Vahid, I'm going to go back 2 slides because I want to show you this one right here when we're talking about the after we talked about the anterior wall and the lateral wall, the infraorbital nerve. Sometimes it can hang down like a bulb in the sinus. Sometimes you find it here. I have another photo where it's hanging down from the ceiling, just like a bulb. Okay, so moving our CT anteroposteriorly to try and locate it is key.
Thank you.
Sure. We're talking about the sinus membrane now, and the average thickness is about 0.3 to 0.6. So it's very easy to tear. As a matter of fact, plan on it tearing. As a matter of fact, whether it tears or not, we're going to adopt an approach today where we don't really care. Okay, no, we don't. It's not that we don't care about the membrane. We don't care if it tears or not. We're going to protect it. Now, have you ever heard about the membrane providing nutrients to the graft? Have you ever heard that? Okay. Like, because it has blood vessels, so it's going to be part of the feeding mechanism into our graft. Okay. Bone originates mostly, okay, from the bony walls. Okay, now this is key. This is key. I'm going to change glasses. Better. Okay. All right. You will find it among some research and very respectable research saying that we want to keep the integrity of the Schneiderian membrane because it will provide blood supply and nutrients to the bone graft that we're placing in the sinus. It may, but it mostly comes from the bony walls. What does that mean? We want more bone and the sinus to be exposed. Okay, the more bone we expose, okay, the more blood we're going to give the graft. So when we open the sinus and reflect the membrane and push it up, okay, and then we get on the floor and we push that membrane on the floor, and we don't lift in the posterior wall, okay, we are actually leaving a big area of bone that is not exposed. And we're depriving our graft from essential nutrients. So if we want good graft turnover, okay, then we must expose every bit of bone that we reach in order to feed our graft. Very good. Okay. Osteoblasts. And I know we're clinicians, we're working now. So don't give me numbers, don't give me classification, don't start talking to me about, oh, the osteoblast is 20 microns in size. Okay, well, how is that going to help? Okay, what does, I mean, when I'm doing a sinus, I'm hoping and praying that osteoblasts come to the area, okay? But what size they are, it's not like I'm going to see them ever, okay? Why are you telling me this? I'm telling you this because of that. When we do GBR processes, okay, when we do surgeries, when we do a little bit of buccal bone graft, okay, we want to increase width. We're hoping for maybe 3-4 millimeters, okay? But if you have a totally pneumatized sinus, then you're going to raise 10-12 millimeters, okay? Now, a 20 micron creature has to crawl all over and reach everywhere, including the center of your graft. Okay, hence you want, exposing as much as you want from the bone, as much as you can. You take your curette and you lift the membrane on the floor, on the mesial and on the distal, superiorly, okay? And then you take that membrane and then you push back and you try to expose so much of that posterior wall, okay? Because that is what's going to feed. That's where your osteoblasts are coming from, okay? Hence, the number 20 microns becomes important. So think of the size of the graft and think of the size of the bone cells that have to come and regenerate everything. Okay. They did a study on the regenerative potential of the Schneiderian membranes. There's going to be lots and lots of studies here, and I did none of them, okay? I'm copying, and the reason why I have the studies here is because I don't want you to think that you're going to go and do this procedure on my say-so, okay? We're evidence-based, okay? So I'm bringing the evidence that's convincing me to adopt certain procedures and start applying them, and so do you. If you're not convinced with the method that we're going to use today, that's absolutely fine. Look for other methods. Also look for the studies that they've done. Okay. So they want to study. They want to see the amount of regenerative power that the Schneiderian membrane has. Okay. And here's the words: may contribute to sinus bone regeneration. May. That's not a sure thing for me. Okay. So as a matter of fact, what we're going to do today, the method we're going to learn, what we're going to apply, we are not going to depend on the membrane at all. Okay? You were going to get rid of it, yes. So it is not a significant source of de novo bone or new bone. Okay? Now, remember from histology? This actually makes sense, okay? You have the pseudo-stratified ciliated columnar epithelium. They're standing right next to each other, like the pins, in a bowling alley, okay? And they've got little hairs on top of them, and that's what they're doing. They're moving the hair at a rate of, I don't know, 15 times a minute or something. So they're actually moving. It's quite a significant amount of movement, and some is mucus, some is serous, and what it's doing is moving everything up and goes through the ostium and it goes down. Okay. It's moving things up. What happens when you impede that movement? Okay. You get sinusitis. Okay. Chronic sinusitis. Now you superimpose that with some virulent organisms and you get acute sinusitis. Why is this important? Because it will have to do with how we're going to prepare our patients before, during, and after surgery. Okay, just keep that in mind. Okay, and some of the things they're going to tell you are going to give you certain indications, whether they're headed, when we get to the complication section, whether they're headed towards, acute sinusitis or not. Okay, but this very thin membrane, it's got a lot of cells, and those cells are very actively moving, producing and moving fluids up and down. Okay. All right. Can the membrane be thicker than 0.6 millimeters?
Yes.
Yes. Okay. Somebody with chronic sinusitis, yes, it's going to be hopefully 1.2, 1.6, 2 millimeters. Hey, the thicker, the better, right? We can actually cut that membrane. Okay. When do we cut that membrane and why? And it's actually very resistant. If there's any pathology in there, you can actually open the membrane, cut it, and take the pathology out. Are you seeing the photos? Okay. And then here we are. Do you abort? You don't abort. Okay. You proceed. You continue. And here we are. So it's a bit of This is what I've been talking about, the cilia beat towards the ostium. And as a matter of fact, it moves at 15 cycles per minute. Okay. Yeah. And any changes to that will cause changes to the ostium, and that can cause sinusitis. So these are the slides discussing what I just said. Okay. Again, I want to talk about the osteomeatal complex. It's very, very important. Okay. The area into which the sinus drains is called the infundibulum. Okay. And it drains into the middle turbinate and it opens straight into the back of the nose. Do that. It's coming from your sinus, it's going back, it's going. When you close, we want to make sure that it's patent and open, okay, before we do any sinus lift. So you take your CT, you're doing your mesodistal cross section, you're looking at it, and then you're going anteroposteriorly. Once you get these slides, there's a site here that you can copy and paste this and go to this website, and it actually has, if you want to look at head and neck anatomy, it will show you everything, and you can actually click and it will remove remove tissues, it will remove bones, it will remove vessels, nerves, so you can actually do dissection. It's very, very interesting. So here's the website you can go to, and sometimes I go on it and I just, refamiliarize myself with, tendons, blood supply, muscles, whatever. Okay. Again, this is a cross-section of the osteomeatal complex. The ostium opens into the infundibulum, which is the in the nose, and if it's blocked, it's going to cause sinusitis. And this is from cadaver. And this is from an endoscope from an ENT, not from mine. Do you see the ostium on the top there, that little spot? Near the letter C? Okay. Okay. I think dentistry is better than me. I don't know. I don't know if I can look into noses all day. Okay. So one of the things that we look at, okay, think about it. How many times will a dental patient have their head examined this way? How many times will they get to see their sinuses, their orbits, and if they have anything going on in their noses, like what's happening in this slide? Do you go? Have you gone? I haven't seen an ENT doctor ever. Okay, maybe when I had my tonsils taken out, 50 years ago, But then who goes and gets a CT done and looks at it? Okay, so we actually have a privilege of seeing things that they don't get to see even with their, primary care physician. And they're fascinated. If you ever sit with a screen and open a CT, the patient is just mesmerized. Okay, they just sit there and they make a comment like, "Oh my gosh, what is this? What is that?" And you can pick up things, and then you can choose to send them to an ENT, specialist or something, or say, "Hey, do you snore at night? How is your sleeping? The wife's just like, yeah. He's like, no, I don't. The wife looks at him with a shock. It's like, of course you do. You sleep with your mouth open. I didn't know, but all that stuff. But look at the ostium here. Look at the OMC. On the very left, it's patent. You can see this dark line. You can see the black line. So it's open. But look at the one on the right. It's occluded. Okay. Look at the septum. Look at the nose. So you can send them to an ENT. They're probably not aware of this, So it's truly a privilege to be able to examine this, note it, okay, and I strongly recommend it, you refer to an ENT, and I ask the patient to go see, PCP, get referral to an ENT. I put it there, okay? So make sure you make a note of it, okay? Remember when we talked about the number 40? Okay, this is a very good sinus lift. Came dangerously close though, right? Okay, came dangerously close to closing that ostium, but it didn't move. The ostium is very patent, as you can see, and that's good. Oh, let me go back here.
How far did they put the bone? How big?
How high? I didn't measure, but this is I want to say this is maybe 25, 30. This is at least 3 centimeters. This is very high, yeah.
They want-
You'll see some nice photos. What about this photo right here? What about this right here? Would you do a sinus lift on this one?
Knowing the history, I mean, patient's history.
Knowing the patient's
Smoker, not
history?
smoker, they can proceed.
Yeah. I like this one. When I see this, I'm not intimidated. Because less chances of remember, chances of tear. Remember the study, oh no, we haven't gotten to that yet, but I think the thicker the better, to a certain degree. That's not 0.6 millimeter in thickness. This is a little thicker, and this will take a little abuse from our curettes. Okay. Vascularity, blood supply. Now, remember we were talking about the transverse artery last year and the year before? What about the infraorbital artery and the posterior superior alveolar artery? The inferior orbital artery gets in the bone, okay, and it has intrabony and extrabony. And the posterior superior alveolar has both intrabony and extrabony branches. And then the inferior orbital and the posterior superior alveolar, they anastomose. So there's a lot of blood vessels going there, okay? When looking at a CT, you try to locate the artery, you try to locate the blood supply, and then what you do? Dr. Vahid, if you find, like in this photo right here, you see the blood vessel?
On the CT scan?
Yeah?
Yeah.
Where would your cut be?
Well, depends on where you're trying to do the bone graft, right?
Yes,
Gotta be below.
it's gotta be below.
Absolutely.
The point here is that there's a lot of blood coming to the maxillary sinus, a lot of blood coming into the maxillary sinus. How does that translate into clinical sense? Bleeding, okay? You are going to face bleeding at one point or another, whether you pick it up on a CT or not, okay? Now, we're going to deal with the bleeding, and we're going to see how we're going to deal with the bleeding and what system to use to deal with the bleeding, okay? But there's one very important factor here that we must remember, okay? We don't want to obliterate that blood supply, because what does blood supply do to our graft? It feeds it, okay? So the two things that we take away from this slide: there's a lot of blood supply coming into the walls of the sinus from the inferior orbital and from the posterior superior alveolar, extraosseous, intraosseous. They do anastomose, okay? And the second clinical importance of this is that we're going to have a bleed, and we must be able to be prepared to handle it, okay? Now, the sizes of those arteries, are about 1.6. That's the mean size, okay? So if it's in bone, you are going to pick it up, okay? You're going to see the 1.6 is a significant number, and you'll be able to see the artery running in the bone, okay? There's also blood supply coming from the posterior, okay? There's coming from the sphenopalatine artery, okay? And the lateral nasal and the posterior septal artery. Lots and lots of blood supply coming to the area, okay? Now, the intraosseous artery has the potential to cause bleeding complications in about 20% of cases, okay? That's a significant number. And sometimes the crestal approach is not an option, or it's not easy, okay? We must proceed with the lateral window. So, in the slide here, can you see the artery? It's separated. It was laying on bone. It was extraosseous, and it was couched between the membrane and the bone. And here it is on the probe. Okay, you can see it. So you can actually dissect it if you want. I just, if I find it and I can easily push it away from me, I'll do it. I do not want to upset it. When a patient comes and we're doing our dental and we have decided we're going to do some kind of bone grafting for that patient, and that's going to involve sinus lift, we must assess the sinus, okay? When we look at the CT, we're initially looking at what? We're looking at the anatomy, we're looking at the ostium, the osteomeatal complex, we're looking at the blood supply. Are we all okay on this? Okay. We want to see if the membrane is thickened, if there is a cyst, if it's half filled with fluid, if it's, if the ostium is plugged or patent, okay? And these are the things that we can see on a CT, all right? But there are signs that we can see when the patient sits down, okay? And if, my cheek is hot on this side, and you can see the little redness under the eyes, and you can okay, acute sinusitis. Those are the things that you want to pick up on, and you want to be very, very aggressive. Just go medieval on it, okay? Don't wait. Don't just prescribe penicillin. As a matter of fact, I rarely prescribe amoxicillin anymore, okay? If I do, I'm always giving Augmentin, okay? Because I don't know the patient, and I know people have a tendency to take drugs all the time. They feel tired, they go and they take antibiotics, they take Tylenol, they take ibuprofen, they call their doctors, don't want to see them, prescribe penicillin, amoxicillin. So it's overused, okay? What I do is I give them Augmentin, because I'm assuming already that they have some kind of resistant bacteria, okay? So I give the Augmentin 875. I have them do it 3 times a day, and I give them Flagyl 500. I have them do it 3 times a day. And I'm going to tell you about the drugs in case they are allergic to penicillin, okay? Some of the bacteria that exists in there is very, very virulent, the Streptococcus and Haemophilus influenza and the Catarrhalis. Very, very aggressive. Some of those infections can last into 3 to 3 months. If you ever had sinus infection, it doesn't go away in 5 days. It doesn't go away in a week or 2. That thing persists and stays for months, 3, 4 months sometimes, okay? There it goes. Chronic sinusitis, it's there for 3 months, okay? Now, when it's chronic, it's not, the symptoms are not as, of course, they're not as severe as the acute sinusitis, okay? But they're still bothered, okay? you will definitely get to see signs of that on your on the CT. Okay, when the sinus is felt like that, when the membrane is thickened like that, no, thank you. I'm not going to do the lift right now. I want to see some kind of resolution, and you will know why. Okay. They did the study. They took 45 patients with sinus lifts, evaluated between 1 and 5 years. Okay. And the post-op, people with who had maxillary sinusitis had predisposition for sinusitis. So if somebody has chronic sinus infections or has had history of chronic sinusitis, they are probably going to get chronic sinusitis or some kind of infection or inflammation after you do the sinus lift. Okay? It does not preclude them from getting the procedure. It just puts them at a higher risk of getting sinusitis. So post-op chronic sinusitis appear to be limited to patients with a predisposition for this condition. So you get a patient who says, I always have sinusitis. I get chronic sinusitis a lot, okay? This patient, you do a sinus lift, they have a predisposition to get sinusitis. It's not a contraindication. They are not always going to get it. Okay, is that clear? So don't be afraid, but you manage it well. You let them know, you know, you tell them ahead of time, you know what you're doing. You tell them after the fact, you're making excuses. Okay, so on the medical history, check for chronic sinusitis. Ask them if they've had, you know, chronic sinusitis. If they had, you know, nasal problems, sinus problems, you know, they may not be aware of but if they've had chronic sinusitis, they'll know.
Do you prescribe tablets beforehand?
Yes, I do.
How about the like Sudafed
We
or nasal spray?
we give nasal spray after, yeah, and and as a matter of fact, I have a full slide with that with all the drugs that we give. Yes, we do. Okay. All right. So you've taken good history of your patient. You know, we know they're not being treated for any severe cardiac disease, malignancies, uncontrolled diabetes. We've looked at the anatomy. We've asked, you know, we've looked into their sinus history, if they've had chronic sinusitis or not. Next, we're going to do our sequential 3D analysis. We're going to take a full CT, okay. I want to see the orbits. I want to see all the way back to the back of the sinuses. We're going to go from right to left, and then we're going to go from front to back, and we're going to assess height of bone. We're going to assess width of bone. We're going to assess the osteomeatal complex, okay, and all those good things. Now, don't blame me for repeating things, okay? That's the only way. On average, I'll repeat things 3 times. I'll repeat slides sometimes 3 times, especially important ones, maybe more than 3 times, because I want to drive a certain point home. Okay? Benefits of interactive CT diagnosis. Do I need to preach that? You all know it. If you've been around me for a week, you know, without a CT, it's a no-go. We're going to assess any pathology. Okay, is it small or is it large? Okay, is it bilateral or unilateral? Okay. This is a nice sinus, a little bit of thickening. Okay, osteomeatal complex is open. I know my anatomy. I know there's no pathology. The patient doesn't have a history of chronic sinusitis, so I know I'm good to go. And so my complications, my surgical risk, you know, there's a little bit of thickening on the membrane on this slide. So I know this one, and I'm looking at I'm looking for the blood vessels in here too. I know that I will most likely have a very favorable outcome Okay, right now what I'm thinking about is my extent of the window, and that when I'm lifting the membrane, it's not going to tear. And if it does, doesn't matter because we're still proceeding. Again, the mesh classification. Okay, 1, good bone, 4, less bone, and then we add the horizontal aspect to it. Okay, of course we want high bone and we want wide bone. You see the photo on the bottom. The photo on the top, we have sinus pneumatization on the bottom there. Okay, I would rather have a wide ridge. Okay, I prefer a wide ridge. If I don't have any vertical bone, that's okay. But please, I want it to be a wide ridge. The wider the ridge, okay, the more successful the lift will be, and the more room I'll have for place whatever type of implant, whatever size of implant I want, and whatever angulation I want. Okay, so we know we're going to do the lateral lift, so that's not an issue. We're going to open the window, we're going to lift the membrane, we're going to put our graft. Now, if we have a thin ridge, that's a problem. If it's a wide ridge, we can do it. What do we do when we have a thin ridge? We'll get to that point too. Okay. So we're talking about our preoperative preparation. We're giving them amoxicillin with clavulanic acid. That's the, okay. I either give that or I go to the Levaquin right away if they're allergic. Okay, so it's either Augmentin or go to Levaquin, and I add metronidazole too. 500 milligrams TID, and the Levaquin is 500 milligrams QID, so they take it 4 times a day. If it's a very healthy patient and we don't have an issue, what we do is I prescribe Z-Pak. Z-Pak, patients comply with Z-Pak because it's 2 pills the day before surgery and then one for 5 days after that. Okay, but if they call me and there's any hint of any inflammation or infection setting in, I immediately switch to Augmentin and Flagyl. Okay. You want to give them some decongestant. You can use Afrin nasal spray, 2 puffs per nasal spray twice a day. Okay. Corticoids. If we're doing the case under IV conscious sedation, I'll have the doctor inject some steroid, and just to give them some anti-inflammatory push. Of course, think about if they're diabetic or not, okay? If not, then you can give them what's the name of the Medrol dose pack. Thank you. Yeah, I give them Medrol dose pack, and you can have them started a day before, along with the antibiotics as well. Okay. I know certain surgeons who really do not want to use any dexamethasone at all. Okay, they don't do it. I worked with another surgeon who used it regularly, even when doing third molars, they would inject some of that in the buccal fatty pad and leave it there, and say and have some people believe in it, some people don't believe in it. I tend to use it if I'm doing IV conscious sedation. And if the patient is not diabetic and they seem frail, then I would give a Medrol dose pack as well. Okay. Sedative. It all depends on how you are set up in your office. Okay. I don't do oral sedation. I do IV conscious sedation. Okay, I don't want to have to deal with oral sedation. Okay, I have IV conscious sedation. We have Dr. Keen, Dr. Montgomery. They come, we do either general or conscious, and the patient is accompanied by somebody when they come and when they leave, and we're good. But I don't give them sedative. But if you're in the office and you are used to doing oral sedation, and you have a monitor, you know, pulse oximeter, pressure, and all that, you can give them Valium. You can give them 10 milligrams the night before, and when they come in the morning, they can take another 5 milligrams or so. I usually give less. I give 5 and 5, unless it's, you know, the volume is, the patient is a big, you know, heavier patient, then I'll give them 10 and 10. Okay, but I tend to be on the lower end of things than on the higher end of things. Okay. Analgesic, and you've been around, you've been doing surgeries with us for a while. What do we give patients? We give them 2 drugs. Give them ibuprofen and Tylenol. Okay, go over the Tylenol and ibuprofen, and I hardly ever have to describe Norco or T3. Okay. As a matter of fact, now the post-op instructions, I don't need to go over that with you, okay? But here's I want to discuss 2 things with you, okay? I want to discuss drug abuse and how to control patients' pain without giving them opioids, okay? Unless they, you know, they call back 3 days later, and then I give them. But other than that, now here's the study right here. If you give them ibuprofen 800 every 8 hours, and then Tylenol every 6 hours, okay, that's equal to what you would give them if you give them an opioid. Okay, they bring that regimen brings about the same amount of pain relief that Norco or Percocet bring about. Okay, so I give them ibuprofen 800, and I take 1. 2 hours later, take a Tylenol, and then 6 hours later, after your Tylenol, take an ibuprofen. Wait 2 hours, take a Tylenol. If I am not sure the patient is going to follow, okay, the routine, because it's a little bit complicated, then I give them ibuprofen 600 and Tylenol, and I have them do it 1 of each every 6 hours. 6 hours. Okay. You know, so gauge your patient. And usually after I give the patient the post-op instructions, I ask him, so what are you going to do? What are you going to do? And most of the time they forget half of the instructions. So I go over it again and have them tell me the instructions back again. It's very important, okay? And if they're sedated, they're not going to remember a thing. So I bring whoever has come with them and I say that's right. Of course, we have this printed, but I say it out loud too, okay? And I say to the person who brought them. This way, they don't say we didn't know, we forgot, whatever. But if I give it, you're the wife, you're the husband, you're the son, the granddaughter, whatever, that's what you do. Here's a paper, but we went over it. They're not going to remember anything after the surgery, but make sure that they follow this. And the patient will sit there totally coach. It's like, oh no, I know, I get it. And they'll converse with you and they'll come back for post-op check and they don't even know who you are. The one more thing I would like you to, now this is totally up to you, okay? Stella Life. Have you ever heard of Stella Life? Okay. It's an extremely powerful additive to your armamentarium, okay? Now you can do one of 2 things. You can either buy the stuff, the reps are going to come to you and they're going to try and sell it to you so you can give the patients, okay? I will give the patient and have them buy it. Okay, it is not inexpensive. Okay, that costs it's a little bit more expensive. It's not covered by insurance either, but the results are amazing. You can get gel, you can get mouthwash. Okay, and here's a result. Okay, here's a free gingival graft. 5 minutes later, look at the graph. Okay, full arch. 5 minutes later, look at the tissues. Okay, if that's what it does in 5 minutes, think of what it can do in a week. Okay, so they have it in mouthwash, in gel, in spray, many ways to do it. Okay, of course, they want you to give the patient the gel, the spray, and the mouthwash. Okay.
What's the active ingredient?
I don't know. I don't know. But it's all natural. It's all natural stuff. And as a matter of fact, it's this doctor right here. These two doctors. I think they did the company, and they're big believers in no narcotics and still alive. But it's big. I've seen it. I've used it in other offices, and it's really amazing.
Question, Dr. Carmi.
Yes.
Do you think that they will sell to us so that we can, we can sell to patients, or do you recommend that we just tell patient go buy it?
I'll tell the patients to go buy it, but here's my experience. Patients do not feel like they want to pay any more money. You just charge me for a sinus lift. Now you want to give me a couple of bottles and sell the bottles to me. It doesn't look good. Some patients may buy it, some patients would buy it begrudgingly, and they're like, no, thank you, I'll pass. So I'll say, hey, I don't sell this stuff. It's there. If you want it, go buy it. Unless I already build it into my fee structure. Okay. And then I can give it to the patient for free. So either this or that. But Dr. Lee, you tell a patient, we're going to do a sinus lift for you for what? $2,000. And we're on the low end, and they're going to freak out, and now you have to pay $50, $80 to get this, and it's not covered by insurance. So if I'm charging $4,000, $5,000 for a sinus lift, fine. So I don't know. So I normally tell patients to go buy this stuff.
Okay.
Yeah.
No, if it will improve the results of our surgeries, implants and grafts and sinus lift, I think we should I'll give it to the patient.
Mostly
cost.
the soft tissue aspect. Mostly the soft tissue aspect.
But we do PRF already. That's helping that too.
Say again?
We're doing PRF.
We are, yes.
Does that also improve the soft
For
tissue?
soft tissue, yes, because they have all those cytokines. Yes. Okay.
Thank you.
So it's really a personal preference. If you want to buy it and give it to your patient for free, if you want to sell it to your patient, or if you want to tell them to go where to buy it, I think I leave that up to you. Are you all familiar with piezo? Okay. Are you all familiar with the Elman unit? Radiosurgery. Okay. Are you all familiar with the bone tack hammer, the tag thing? Okay. All right, good. Now, you don't need a piezo surgery. Okay, you don't need a piezo unit. You can get a good straight hand piece, get a big round burr, 6 or 8. I don't like the carbide as much. I'd rather use the diamond. Again, that's a personal preference. Okay. And you can open the window a lot faster this way. Okay, because it's going fast, got water, boo, cut, remove it. when I first started, I used to do that. I used to use the handpiece and I used to open the window and, you know. And then later on, I started using the piezo and my technique changed slightly as well. Okay. So it's a personal preference. If you think you can remove the bone with the handpiece and you have the skill to do it and with, you know, without going through the membrane, fine. But if you want to use the piezo, fine. Let me tell you a secret. The piezo and the burr can both tear through the membrane. Okay. If your hand is not sensitive enough, so you don't need to buy a piezo to do sinus surgery. Okay. I prefer it because there's a study that I'm going to show you next. Okay. Piezo is kind to the bone. Okay. And the study that I'm going to show you later on, it will show you that there has been significantly less post-operative pain when using piezo surgery. Okay. If you're going to do a ridge split, okay, piezo is very good, especially if you're working down in the mandible. I mean, you're pushing those pieces of bone apart. They're going to have some kind of discomfort, you know, but if you can lessen and decrease and control that post-operative pain, the more you can, the better. Okay. And what I like about the piezo as well is that it has those different tips. It can help you start your sinus lift, moving the membrane. This drill right here, the one that's on its own, like the elephant foot there. That one you can after you remove the window, you can get it underneath between the membrane and the bone, and it will push the membrane and start your lift, okay, without puncturing the membrane. Okay, so I like those different tips and the facilities they allow me to use the piezo. Okay, now that versus the regular technique. Okay, regular technique. That's not what I mean by number 8 burr. Okay, you can use this, and what you'll do is you're just eating away the bone. Okay, as a matter of fact, one of the opinion leaders, one of the most successful sinus lift doctors, I took a lot of the stuff from him for this presentation. Takes away the bone. He actually uses a burr, cuts a window, and he even chucks that piece of bone. He doesn't use it. I disagree, and I'll tell you why. So you can denude the bone using these, or you can use them to open a window and keep the window. Now, here's the case, the study I was telling you about, where, you know, using the piezo surgery and here's the conclusion: sinus lifting procedure performed with piezo surgery causes less pain and swelling post-operative compared to conventional technique. Okay, so their daily life is not affected as much. Okay, now radiosurgery. We have a unit. I'll bring it out and I'll have you. Whoever is doing the next sinus lift, I'll have you use it. Radiosurgery. This is actually a lot of doctors that are doing facelifts and, you know, a lot of those cosmetic surgeries use it. Okay, you can use it for two things. One, a very precise cut. Okay, it doesn't produce heat like electrosurgery. Two, you can use it for bleeding control. Okay, so it is not inexpensive. It is a piece of equipment that you have to invest quite a bit of money in, but if you need it, you need it. There was just about 3 weeks ago, I was doing surgery and in a spot that I did not expect in the anterior mandible. Okay, blood started to squirt out, okay? And we spent maybe 20 minutes to control the bleed. We stopped everything, we just spent good 20 minutes trying to stop the bleed, okay? I wasn't afraid, okay? But it was certainly, and the patient's mouth is filling up with blood. You have to stop the surgery, they're more prone to infections when they're open for a longer period of time. I don't want blood to pool under the flap, and and it will harbor bacteria and it can cause infection. So when you need it, you need it. And radiosurgery, it has many tips, like round and many tips, not a lot, but quite a few. One of the tips is like a little clamp. Okay, so if you sever a little artery in the bone, you can take that clamp and it will actually shut it. It will stop the bleed for you. So it's, if you're doing a lot of surgeries, and if you've had bleeds before, and if you don't want to be fumbling around, it might be worth a look. Okay.
Guys, it's involved.
And I'm going to share with you at the very end, I have slides where you can get any and everything, okay? Where you can go and you can get any and everything, all right? So where do I get this? Where do I get that? How much it will cost and all that you're going to find. It's not the same as electrosurgery, okay? Electrosurgery produces heat, okay? So it's cooler. So it's a lot less damaging to the surgery. So it produces postoperative comfort, minimal scar tissue formation, and if you're taking a histological specimen, it's not damaged, enhanced healing, and excellent cosmetic results. We're not working in the face, but when I'm always happy when I don't see my lateral release cut. Sometimes you see that line and you see the fibrosis. You use this and you get very good healing from it. I will sometimes if I go through three slides, I will combine them all in one slide so you can have a bird's eye view of the previous three that we've gone over. Okay. Curettes. I have to make this clear. Nobody pays me money. I'm owned by no Salvin or anybody. Okay. I mean, Salvin is a place where you can go and find other stuff. Okay. So is eBay. Okay. You can find a ton of curettes on eBay. All right. And they're a lot less expensive than you want them than you find them on Salvin. You want Salvin? Get Salvin. But you want Henry Schein, Peter Patterson, whatever. Whatever you're going to end up doing is you're going to end up with 3 or 4 curettes that you're comfortable with. These are the ones that have the angulations and the length that will fit most of your work. I tend to get a big kit because every now and then I'm thinking, I wish I had one that was just 5 millimeters longer. I wish I had one that had an extra curve to the distal or whatever. So I collect curettes, okay? And I keep big kits just in case, all right? So it's a personal preference. But at the end of the day, you're going to have your curettes, your retractors, scissors, and the auto tack. It is very important. If you're serious about doing any kind of bone grafting, any GBR procedures, auto tack, you must have it. Okay, you want your screw kit. Okay, if you're doing tenting screws, but there's a kit. I'm going to show it to you at the end that has the auto tack, the screw kits, and all that stuff. So you got everything in one big heavy box, and you're ready for surgery. You're not, oh, get me a 4 millimeter tack. I need an 8 millimeter screw. No, not that one. I want the Phillips head. No, I want the This one kit has everything, you're good to go. Okay, materials. This is one of the most important things you're going to need when you're doing a sinus lift, okay? Listen, you want bovine, cross-linked collagen membrane. Okay, I'll say it again. Bovine, cross-linked collagen membrane. It's resorbable, of course, okay? Now, if you buy it from BioHorizon, it's called Memlock. You will find it in many, many other places as well. But what you want, not the brand, okay? Don't look for the brand. Look for collagen membrane, okay? That's cross-linked. What this does, it holds its shape. So when you're handling it, it's not sticking to every blood vessels and flap and all that, okay? Okay. PRF. Who here does PRF in their offices? Yeah, Dr. Vahid? You, PRF, it's easy, okay? And it's extremely, extremely useful. It helps a lot with post-operative healing, okay? Minros, that's the membrane or the, that's the bone or the bioos and the suture material. Xenograft, pretty much, okay? So if you can get xenograft, you'd be fine. You also want allograft, okay? So we're going to do our sinus lifts using a mix of xenograft and allograft. I never put xenograft in my sinus lifts before, okay? I sprinkled a little bit so I can see it on the x-ray. But generally, I never did a sinus lift xenograft. But then I looked at the European site and I looked at their studies and I looked at their x-rays and I found that they're using synthetic and bovine and everything is working out fine. And as a matter of fact, a doctor from Brazil, a periodontist, doesn't use any. And he showed me through study after 15 years worth of stuff. It works. And I think I prefer it over allograft right now, and I will tell you why. Suture material. Okay. Here's the membrane. What is it? Bovine, cross-linked collagen membrane. Okay. And what you do is when you're inserting it in the sinus, you cut the corners of it, and you put it in. And you'll find, and now the PRF, and I'm going to talk about PRF ad nauseum later on. Okay, that will take us to a whole different conversation, but the machine that we have, the centrifuge, you can set to PRF, LPRF, or CGF. Okay, so for our purposes, we're going to do the LPRF. Okay, it's basically just how the whole thing is spun and what kind of cells are found in this fibrin clot. Okay, it just increases the stem cells in the fibrin clots. Okay. Bone. Okay, all right. Now, when you're buying bone, what particle size do you want? Okay, you don't want it too small, okay, and you don't want it too large. So somewhere between 800 and 1200, okay? 650, 1000 is what you want. 850, 1000, okay? You don't want those big chunks, okay? Unless it's, like patient's own bone, okay? And you don't want the very fine. It won't stick together. The handling will be a lot harder, okay? As far as sutures are concerned, I put these sutures on the top, and I will tell you why I don't like any of them. Okay, PTFE. I used to use PTFE. I love PTFE. Okay, it's monofilamentous, right? It's just that one thread. It's very soft. It's very kind to the tissues. But once you tie it, it stretches. And then it becomes really hard to work with it going forward. Okay, I don't like PTFE for that reason. Vicryl is good, but we got better. Nylon is good, but you cut the nylon, and then what does the patient complain of? It's poking. It's very sharp, and it just stays there. Okay, and you're darned, like you put it on the buccal, it's bothering their cheek. You put it on the lingual, their tongue is always hitting it. You put it on the alveolar, and their tongue goes there too. That's why I like using the premium PGCL. Okay, and this is where you can buy it. You can go to AD Surgical, and you can find. And I'll have all these later on, and you can go there and I like the 4O. Okay. And if you're colorblind like me, get the violet. Okay. Because there's the undyed PGCL. I am good for one suture. And then after that, I can't see the darn thing. Okay. I cannot see it. So I like the violet to be able to see. 4O is what I go for. And there, I gave you my reasons. Okay. Incision. Incisions, when we go to have you ever heard Dr. Dennis Smiler? He's an oral surgeon up here in LA. He goes, big surgeons do big flaps, and he's like, I don't want you doing a sinus lift and doing a little incision, that big. You're not gonna see, you're not gonna get to it. Okay. So you want to, if your border is the anterior mandible, anterior wall of the sinus, then you're probably going to extend to the canine. Okay. And if your posterior is going as far as number 2, then you go posterior to number 2, almost on your tuberosity, and you do a releasing incision, and you lift everything up. Okay. The first flap, you're going to lift up using your periosteal elevator. And then as you go back to the posterior, you're getting very close to very, very sensitive areas. There's a lot of anatomy there. You want to do blunt dissection. So you want to take a piece of gauze, you put the piece of gauze on the bone, and you're pushing the tissues using the gauze. It will help with keeping the bleeding down, and it's safe to do it that way. And as you're going up here in the anterior area, hopefully you've identified where the infraorbital nerve is, but again, you can never be too careful. Okay, use your piece of gauze to open up. Now, if you take a suture, you can use a 3O chromic gut or plain gut, and take your flap and suture to the buccal mucosa. In the front especially, this will make reflection so much easier for you. So the flap is out of the way anteriorly, and you're retracting in the posteriorly anyway. Okay. So again, you can use the round burr, or you can use your piezoelectric, and you can do a round window. When I use the piezo, my geometry is always going a rectangle. Okay, I always do a rectangle. I take the window and I keep it in sterile saline, and I put some antibiotics in the saline solution. Okay, and then I take that window, and after I'm done, I put that window back. Okay, Dr. Picos takes that window and chucks it. If you don't want to put the window back, you want to take it, grind it, and put it in your bone graft, because that cortical plate has a lot of BMPs, go ahead and do that. Okay. Now, there is a way where they actually do the window, do the anterior cut, posterior cut, inferior cut, and the superior cut is only halfway through, where it's like a hinge, and then you take the window and you push it up. I don't think it's necessary to do that at all. It sounds nice and smart, but what's that piece of window doing up here? Protecting a tear in the membrane. We're going to use our membrane for the membrane, right? So we take that and we can either put it back on the window or we can grind it or chuck it, up to you. I would rather put the window back or grind it and put it in the bone. Now we're going to layer the bone. Okay, your inferior cut is very important, okay? So the anterior cut we talked about is going to be as far as possible to the interior wall. And the inferior cut, you want to be about 2-3 millimeters above the alveolar floor, okay? You're not going to go flush with it, but 2-3 millimeters above it where you have a very gentle, like a slide to go and reflect the membrane. If it's higher than that, you're going to have a lot harder time reflecting the membrane. But 2-3 millimeters you can handle, and it will give you the visibility and it will give you the tactile sensation to reflect the membrane with all the adhesions and all the bumpiness without tearing the membrane. Okay. How high do we go? Sorry, I forgot to mention that. How high do we go? The window is about 8 to 10 millimeters. Okay, superior. So you're going up, your cuts up are about 8 to 10 millimeters. Now, think of your anatomy. Are you getting was the maxilla totally pneumatized and got, and those 3 plus 3 plus 3 plus 8, is that going to get me under the eye or not? So please do your measurements and look at the anatomical landmarks very, very carefully. Okay, so you do large access and you start lifting the membrane. Let me tell you something. When you lift the membrane, you want to start with, first you want to deflate it a little bit, okay? So the easier part to release is the superior part, okay? So you start your superior release, you start your distal release, start your mesial release, okay? And then you go for the release on the inferior border or the alveolar process, okay? Then it's giving you a little bit of room. But if it's attached in all those areas and you're going to start with the part that's mostly adherent to the floor, you're going to increase the chances of tearing the membrane. Not that it matters, okay, because we're going to handle it, but I still take it a point of, professional pride to achieve it without, doing the minimum tear. Sometimes you'll get tears in the membrane that you will not know about, okay? And here it is. What they're doing here is that they're taking this piece of bone and they're lifting it up high, and they're making that as the superior part of your of the lift. We're not going to do that anymore. Okay. Now we want to fill our membrane with fill our cavity with bone. Okay. So the top part of the sinus, we're going to put what kind of membrane? Bovine, cross-linked collagen membrane. Okay, you get a piece that's 30 by 40. Don't get a small piece, get 30 by 40, and you can trim it however you want. Okay, so get the 30 by 40 collagen cross-linked membrane, and that's going to go on the top. Okay, and then you can mix bone into 2 bowls. You can mix 50-50 allograft and xenograft, and then you can mix 50-50 with xeno and autogenous bone. Okay, so you can go for some autogenous bone. raise a little flap in the mandible, take a little trifine and grab a piece of bone from the ramus, okay, and grind it and add it. Or from the chin, or take a curette and start scraping bone, or the window and grind it and add it to the bone. So we have 3 layers. We have the membrane, we have the xeno and the allo, and then we have the xeno and the autogenous. If you can't get autogenous, fine. But why am I advocating for autogenous at the very bottom layer?
Using the contact with implant.
Yeah, because that's where the implant is going to be. And I want my first 10 millimeter of implant body to be in as much native bone as possible. All this is going to turn over later on, okay? But the more I put, now why do we want the autogenous bone? Because it has osteocytes, osteoblasts, right? And it has the osteoinduction and osteoconductive and osteoblastic abilities. So here's the top layer. We're doing the cross-link collagen membrane, 30 by 40. And then we're doing a mix. And then we're doing third layer, okay? Agreed. I want you to look at this. I have this slide in our bone grafting lecture, okay? And we have our autograft or autogenous bone and the allograft and the xenograft, which is animal bone, okay? And the alloplast, which is totally synthetic bone, okay? What are we looking for? Biocompatibility, safety, surface characteristics, geometry, handling, mechanical characteristics, osteogenic, osteoconductivity, and osteoinductivity, okay? Now they're almost all of them are within the same ballpark. But where the autograft or the autogenous bone excels is that it has the osteoinductive ability, okay? Because it has its own, the bone, it's from the body, it has its own cells, it has its mesenchymal and osteoblasts and okay? But we're counting on blood to invade the area and bring all those cells and bring about good healing of them, okay? So just those definition, okay? Osteogenesis, formation of bone. Osteoinductive is the process by which the osteogenesis, this is how the bone is formed. The osteoconductive is the ability of bone substitute material to encourage bone growth in the area, okay? So xenograft is osteoconductive, but not osteoinductive, okay? That's the main difference between autogenous bone and the other materials. All right. Antibiotics, 2 schools. Some people have a little bit of antibiotics, you know, mixed with the bone, just a little bit, or I don't mix it with the bone, I have it in the saline. So I have sterile saline, I add tetracycline to it or doxycycline. And if I don't have any of those, I use flagyl, okay? And I'll mix it, and that's what I'm doing my rinsing throughout the surgery, under the flap, in the sinus, under the flap, in the sinus, in the osteotomy. I'm doing that repeatedly, okay? And even with the suction, some of it goes away or most of it goes away, but whatever remains in there, okay, will help to be bactericidal. Dr. Pikas doesn't believe in doing it. Okay, other doctors don't believe in it. There's a school that believes in using you know, tetracycline. Some say, oh, it can change the pH in the area and the bone and all that. Honestly, I never sat inside the sinus while it's healing and been able to observe any of those processes. But what I know, just empirically, is that you take some antibiotics because you open, bacteria is going to go in. I just want something to give the body a leg up. Okay, that's it. Okay, it's not a deal breaker if you don't rinse with antibiotic. I recommend it. And it's totally up to you, what you do. Now, when we draw blood and we mix our sticky bone, now packing bone in the sinus, when you take bone and you mix it with saline, it becomes very hard to pack. You know, it's falling, it's going over the ridge, it's falling in the patient's throat, and sometimes you like stuff costs money, right? But when you do the PRF or the CGF, that stuff you can pick it up, and the whole thing is just one piece to a point where we're actually cutting it into pieces and packing it in. So and it also has cells that are going to increase the healing in the area tremendously. Okay. All right. 10 more minutes and we take a break, or do you want to keep going? Yeah. Okay. Let me let's stop right here and come back and proceed. We're gonna take a little break. 5 minutes.